And just for the record, I have to declare an interest as I have a licence to practice on the GMC register. So I want to move us on. I appreciate we're coming to the end of the session. I'd like to focus your attention on registration of internationally qualified doctors. As I'm sure you're aware, we have a piece of legislation coming to Parliament next week, the Medical Training Prioritisation Bill. And Mr. Massey, if I can quote yourself, you've previously said it's vital that workforce policies don't inadvertently demoralise or drive out the talent on which our health services depend. Doctors who qualified outside of the UK make up 42% of those working in the UK. If we see even a small percentage increase in them leaving, our health services will end up with huge holes that they'll struggle to fill. And just to sort of put this in context, we are actually seeing larger numbers of internationally qualified doctors already leaving. So in 2024, 4,880 internationally qualified doctors left, a 26% increase compared to 2023's number. So my question, Mr. Massey, is do you think that this medical training bill risks having an adverse impact? And if so, how can that risk best be addressed?
So a couple of things, if I may. So, you said some of what I would say, so thank you for that. So I think it is entirely legitimate for government to set out plans about prioritisation in terms of allocation of training places with a prioritisation towards UK-trained doctors, because that is it costs a lot of money to train a doctor both through medical school and their postgraduate training. And indeed, we said that in our evidence to the Medical Training Review Phase 1, that the bottleneck in training needs to be addressed. We also said, though, that needs to be done with a really good understanding of the evidence base. So we know, for example, that in general practice, half of first-year trainees are doctors that qualified overseas, and in psychiatry, which is another specialty which has traditionally made more reliance on international medical graduates, 42% of trainees qualified overseas. So to your question, I think it is absolutely legitimate for government, but I think what needs to happen is that conversations about prioritising UK graduates need to be accompanied by clear statements that recognise and value the contribution that international medical graduates make in our NHS. And I think...
So sorry, Mr. Massey, how do you see that working in practice? So when for example, we'll be making offers in 2026, so that will sort of have that prioritisation, and then obviously 2027 onwards we'll be undertaking interviews where we'll prioritise. How do you see feasibly the balance between, as you say, legitimately saying that UK graduates cost a lot to train and therefore they should be prioritised, alongside balancing the need for international recruitment? How do you see that playing out?
So I think it's less about international recruitment, but about the doctors that are already working in the NHS. So it's that 42%.
So this is not new people coming in. This is existing.
Yeah. So I mean, we are seeing a number of international doctors joining our register. We have about 20,000 last year compared to about 8,000 coming out of UK medical schools. But the point you quoted earlier was me really saying we need to be really careful about those doctors that are already working in the UK, because there are 140,000 of them, and if only a small proportion of those doctors, who, remember, are highly mobile individuals, they have uprooted themselves and their lives and their families to come and work in the UK, if those doctors don't feel that they're getting adequate access to learning, development, training, that they're not being supported and valued in the workplace, there is a good chance that more of those doctors may leave. And indeed, in our data last year, we did see that there was an increase of 26% of overseas doctors leaving. Okay. So the question about what should government do about it? So
you're making a differentiation between people already in the National Health Service, perhaps who have qualified from international medical schools, and those people who might be coming afresh. So I think, just to perhaps assuage your concerns, but please tell me if this assuages them. In the bill, the priority list has UK medical graduates. It has persons in priority groups, of which, people who have right to remain, who, for example, who are from Ireland and, did most of their training here. There's a list of 4 countries where we've got a particular special relationship, but they also say persons who have completed or are currently on a relevant qualifying UK programme, and they go on to talk about people who have had substantive training in the National Health Service. Do you feel that covers the concerns that you have around international recruits who have been in the NHS for some time?
So I think the focus on significant NHS experience, so for this year they're government's using visa status as a proxy for experience. For future years, I think the government has wisely left the door open in terms of defining what significant experience means, so that it can be much more nuanced about making sure that those hard to fill specialties get the doctors they need. But I'd say it's not just about the bill and formal postgraduate training. The other thing that we've been saying for some time is that we've seen a massive shift over recent years to many more doctors being locally employed and in SAS roles. And the significant growth of locally employed doctors has been fueled to a large extent by international migration. Those doctors have not historically had the access to the learning and development that I believe they should have. I think it should be much more attainable for doctors not in formal training to develop their clinical skills and experience and step into specialist roles in the future. Not at the cost to formal training, I need to be really clear. This is a very much a both-and position. So this is a particular position that we are advocating for with government in relation to the workforce plan that we expect in the spring, because I think that goes to this point around doctors feeling confident that they have the career progression and value and being valued in the workplace. And we know from our own research those are really important factors in determining doctors' decisions to stay in the UK.
Sure. No, absolutely. So just returning perhaps to my colleagues' queries, is there any risk with this medical training prioritisation bill? And we have been here before. This isn't the first time we've sort of looked at this issue around UK graduates. Is there any risk that you can see whereby we sort of end up with a two-tier system, so to speak, where those specialties that are very hard to fill, and you've already alluded to a couple of them, are filled by international graduates, and we end up with a two-tier system, and we inadvertently end up perpetuating a form of racism that nobody would like to see?
So I think it's too early to say, because I think the bill has only just landed in Parliament. There's quite a lot to be fleshed out in terms of what significant NHS experience means. Well,
it's on Tuesday, Mr. Massey.
It's all on Tuesday.
I know, but my point is, I don't think the bill is the only thing you should be looking at in answering that question. I think the question about what the offer is for the entirety of our medical workforce, whether they're in formal training or not, that is the missing bit of the equation in terms of reaching that judgment about do we have a two-tier workforce.
Absolutely appreciate that, Mr. Massey. You'll appreciate that we're parliamentarians and we have to pass legislation to the best of our ability, and this is the bill that's in front of us. For the General Medical Council, are there any practical considerations with this bill that you would like to make us aware of?
No, I don't think so. I think I've made all the points I would make to, and have made to senior officials and ministers.
Excellent. If I could just, before we move off from the bill, one small point, and it is something that's of interest to me because it is my specialty. So the bill actually alludes specifically to public health as being an area that's exempt from this legislation. So UK Specialty Training Programme means a programme of training required for or leading towards the award of a CCT, Certificate of Completion of Training, but does not include a programme wholly in the area of public health. And the reason, as I understand that, is because there are medics and non-medics that go through this specialty area. Can you foresee any issues arising as a result of this exemption?
Not off the top of my head. And I think that the other point is we need to make sure we are continuing to make other routes to a CCT or to come into the specialist register attainable. And what I mean by that is that people who get on our specialist register aren't just those doctors going through formal postgraduate training programmes. And one of the bits of work we've been doing with all Royal Colleges and faculties has been to make sure that we're really clear about the kind of the criteria that need to be assessed in terms of the skills and experience that make it easier for those doctors to demonstrate they have those skills and experience to join the specialist register. But I don't see anything specific in relation to public health that I see as being immediately worrisome in terms of the bill.
Thank you, that's clear. And just very quickly before we finish, I just want to move on to education, training and development, which is a large area, but I will précis it down. So obviously we hear a lot, and I hear a lot from colleagues about burnout, about people dissatisfied with their day-to-day work, about all sorts of issues, and your GMC survey in 2024, 74% of those responding said that they were likely to make a change to their careers in the next 12 months, and that included 19% who indicated plans to leave the UK. So perhaps that gives us pause for thought with our bill next Tuesday as well. But my question for yourselves is, based on the fact that we're now in this period of the NHS 10-year strategy, we're looking for this 10-year workforce plan that's coming forward. So what considerations arising from your insights into education, training and retention should be foremost in our minds as we look at this 10-year workforce plan?
Okay, so I'll do those in reverse order if I may.
Sure.
So start with retention. So for a number of years we've been publishing our data about doctors' experience in the workplace, and we use that to hold a mirror up, and we've reported high levels of burnout, high levels of workload, which particularly dipped following the pandemic. And last year's report actually showed some gradual improvement in some of those data, but many doctors face real challenges and struggle to provide the patient care that ultimately is what drives us. So we've tried to use those reports, that data, that insight, to have bigger conversations about inclusive working environments. I believe the commitment in the 10-year plan to introduce staffing standards is really important and something we should all put our shoulder behind.
And so, just to be clear, Mr. Matthew, there are no staffing standards currently?
So the 10-year plan wanted... I hope most employers will think about staffing standards and well-being of their workforce. What the 10-year plan said, it wanted to introduce kind of much more hardwired staffing standards, so much more consistency of data, more accountability for boards, that threaded through regulation and system regulation.
No. So it's fair to say the standards are variable at the moment?
Yeah, and I'm a big fan of that because I think standards are variable, and I don't think employers always put as much intention on creating inclusive, supportive workplaces as they should, and I do believe that is absolutely fundamental to those questions around retention.
And I think, can I just ask you to specifically to consider GPs? You mentioned GPs earlier. In terms of making that a career choice that is more appealing, how does the GMC sort of consider its role in sort of building up the education and training and support available to newly qualified GPs? So
in last year's report, we specifically talked about the challenges faced within general practice, and 44% of GPs were struggling with workload. 60% found it hard to provide sufficient care to patients at least once a week. That was much higher than for other specialties.
Yep.
So it's not for us to determine the government's plans in terms of GP numbers, the wider workforce in primary care, but we do use our data to enable people to reach those conclusions.
Yeah. So would you say it's fair enough, Mr. Matt, to say that from your data there should be more GPs in primary care?
I think it's a bit more complicated than that because it's about a much broader workforce that work within primary care. Primary care now looks very different than it did a decade ago in terms of the range of healthcare professionals. So I think it'd be wrong for, even though I'm the regulator of doctors, to say the answer is X thousand more GPs.
I appreciate that. However, if we're moving from hospital to community, and at the moment, as you know, ICBs are getting ready to be the strategic commissioner, and the ICBs are very much looking at primary care to be their sort of lead provider. Would you not say that that is additional burden on general practitioners and therefore increasing either the resources available to them or the numbers that are there to be able to do the work is not an unfair?
So I think to be fair to successive governments, they've put a lot of effort into getting more GP training places, more GPs in. I think the problem is the leaky bucket at the other end. So I think the problem we've got is that the kind of workforce pressures that we've been discussing and the well-being issues and burnout is driving too many GPs out of practice the other end. So this is where I come back to those questions about addressing working environments and workplaces, making sure that people feel properly valued, making sure that doctors have the time to do the things that they became doctors to do, to provide patient care. So for me, it's a much more of an issue about attrition and retention, and that's why, and you mentioned earlier data about doctors saying they would leave. We saw the number of doctors saying they were taking hard steps to leave the profession. That means applying for a job or downloading application forms, double from 7% to 15% between 21 and 24.
Absolutely. So this is not a new problem. I appreciate we had a pandemic and that was very stressful for frontline healthcare professionals alongside the rest of us, but this is not particularly a new problem. So why have these issues that I think you've rightly outlined not been addressed previously?
So I think that's a complicated and difficult question. I think, sadly, working environments are not consistently good, whether in primary care or secondary care. I think it's much harder to get a handle of that in primary care because, by definition, there are many, many more employers.
But I think there is consistency in what general practitioners are saying, and it's been pretty consistent for a number of years as the pressures have increased. So why are we at, essentially, with 2026, and we are saying the same things, and the definition of insanity is saying the same thing, they're expecting a different outcome. Nothing appears to have changed. In your role as a GMC, you speak to a lot of clinicians. Why do you think it has not been addressed?
So I think the issues around well-being and workload and work environment in general practice have become significantly worse since the pandemic. I think the pandemic has driven some massive changes in the way in which general practitioners work and the way in which primary care is delivered in this country. I think many of those changes have been positive, but I do know that from talking to GPs that too many of them feel that the only way that they can survive, and we see this in our data, is by reducing their hours in order to cope.
And is that burnout of clinicians, or is that changing expectations, or is that under-resourcing of primary care, or all three?
I think there are going to be elements of all of those factors that I think we need to take account of, and I think, I appreciate being asked the question about what's the reason, what's the solution, but I think it is complicated, and I think there are some structural issues in relation to primary care. We know that there are far fewer GPs who want to become GP partners. I think that raises questions about the structure and funding for primary care. They're not issues that the GMC has particular expertise.
I appreciate that, but as a regulator, you do sort of...
As a regulator, I'm worried in what I'm seeing in terms of that data, and I'm worried that general practice has consistently come out of our data as one of the most hard-pressed specialties.
Sure, and there is stuff around discrimination, but I think we're out of time, aren't we? Yeah, absolutely. Thank you.